Welcome to EMTprep Pulse Check, the podcast where we help you sharpen your knowledge, ace your exams, and stay field ready. Whether you're prepping for the NREMT or looking to stay sharp in the ever-evolving world of EMS, we've got you covered. Each episode brings educational insights, real-world case reviews, and expert tips to boost your confidence, both in the classroom and on the call. Let's jump in.
Today, we're focusing on PEEP, which stands for Positive End-Expiratory Pressure. Let's get started with a lecture brought to you by Garrett, one of our content creators. Then, we will wrap up with 10 multiple choice questions for review.
All right, today our lesson is going to be on Positive End-Expiratory Pressure, or PEEP, P-E-E-P for short. This is how you'll frequently see it abbreviated. It's an airway procedure that both EMTs and paramedics can do depending on what your scope of practice and how your local protocols are, and we'll talk through how it's used, when it's used, some considerations on when it shouldn't be used, and we'll get into a couple scenarios here. So PEEP is performed to increase oxygen saturation in patients. So the single idea with PEEP is we have patients who are not getting enough oxygen, and PEEP, positive end expiratory pressure, is an intervention we perform to help raise their oxygen saturation. The main idea behind PEEP is that you want an end expiratory pressure in the lungs, the pressure after you breathe out, greater than atmospheric pressure. So as you're breathing out, there's only a certain minimum pressure that your lungs stay above for the end expiratory pressure is the idea. This is achieved by a spring valve that can be attached to a bag valve mask. So BVM for short is what I'll say throughout this lesson. And the spring is basically just something that is against the pressure of atmospheric pressure, so it adds to that pressure. To start thinking about how PEEP works, we'll do a quick review on airway anatomy here, specifically the lower airway. So we'll start with the trachea. And as you work down the trachea, you can get to the carina. And then we're going to talk right about the bronchioles. So that's where you have the bronchi, bigger areas that air flows through after the trachea. And then it gets into the smaller bronchioles, which then break out into the alveoli where gas exchange occurs, as we can see in the image here on the right of your screen. The left part of the image shows a very general trachea leading to the carina, leading to the bronchi, and then if you look in the upper right corner of the image, you can see that the bronchi break off and lead to the bronchioles, and if you work your way down, kind of the middle right side of the image now, you'll see that the bronchioles split into the alveoli, and that alveoli is where gas exchange actually occurs. So air goes in, oxygen leaves into the blood. You can see the top red part, and then as blood cycles through, CO2 leaves from deoxygenated blood and is oxygenated by the air going into the alveoli. So if the alveoli have to be open and working effectively for gas exchange to occur and oxygen to go into the body, which is what the key of what we're talking about today with PEEP is about, is oxygen going into the body. So a key point there is that if the alveoli are not open, there's no way for oxygen exchange to occur. Even if the trachea is open, if there's no airway obstruction, if the alveoli are closed shut or not working, there's no way for the body to get oxygen, which it obviously needs to survive. So, continuing on, we'll talk about the process of inspiration and expiration. So, during inspiration, the diaphragm contracts, right? As you breathe in, the diaphragm moves down, the lungs expand, so they gain more volume, which then creates a negative pressure, right? So this is kind of a little anat and phys review, but as the diaphragm contracts, which can be active as you forcefully breathe in. If you want, you can feel your diaphragm contract. The lungs expand, they gain volume, which as the volume increases, that causes a pressure differential and an inflow of air into the lungs, right? And as the diaphragm relaxes, the lungs contract, so they lose volume. There's positive pressure, air flows out of the lungs, back through the trachea, out of the mouth or nose, and it causes an outflow of air, right? So just considering how the volume of the lungs and the pressure of the lungs is affected during inspiration and expiration. You can use external intercostal muscles to increase volume or increase lung expansion. And frequently you'll see patients with breathing difficulty or respiratory distress be using those accessory muscles to breathe, right? So pulmonary respiration is the process itself of inhalation and exhalation. So air flows into the lungs. We talked about that during inhalation. The lungs expand and alveoli expand to maximize gas exchange. So that's happening during inhalation as the volume goes up. As air flows out of the lungs during exhalation, the alveoli partially contract and they push the CO2 out of them, which we can measure, right, with end-tidal CO2. Lots of times we can hook into cardiac monitors and measure. So here's an up-close look at the alveoli. You can see there are these very, very small break-offs of the bronchiole where they kind of break into the little circles. People call them, sometimes they look like grapes or berries or something. But in each little alveoli, there's a lot of surface area for gas exchange. That's the goal, increasing the surface area where gas exchange can occur, where that CO2 is leaving and the oxygen is flowing in for respiration, correct? So alveoli contract to push air out during exhalation because you want fresh oxygenated air in so the body can get oxygen. But during exhalation, alveoli do not close fully. They lose volume, but if they got smushed together, it would be hard for them to open again because they would be pressed against each other. It's like think about like blowing up a balloon, right? So if there's no air in the balloon, it's really hard to get it going. That's the hardest part for sure. But if the balloon has already started to inflate, it's not extremely difficult to be able to get more air in. All you have to do is breathe a little bit, push the air in, and the balloon will expand a little bit more. A way to assess this in the field is thinking about lung sounds. So when no air can be heard assessing lung sounds, alveoli aren't participating in pulmonary respiration, there's not air moving. If you can't hear air moving through those balloons, which we kind of been talking about, the alveoli aren't pushing air in and out. So in someone who might have not good air movement, you might hear less lung sounds when you're listening on specifically that side, something like that. So talking about surfactant now, it's a lipid protein substance that coats the inside of the alveoli. And surfactant is extremely, extremely important for pulmonary respiration. So the purpose of surfactant is to decrease surface tension at the liquid-gas interface, and then reduces intraalveolar pressure and prevents collapse of lung tissue. So surfactant, it's just think like almost a slippery substance that lowers the surface tension such that those alveoli don't collapse. It's like the balloon holding a little bit of air in so it doesn't go completely flat, if we're continuing from my little analogy earlier. And part of what causes respiratory conditions to have impact on air movement and subsequently oxygenation is that they interfere with surfactant. Things like pneumonia or acute respiratory distress syndrome, CHF, congestive heart failure. These other conditions can cause fluid to accumulate in the lungs, and that fluid can interfere with the surfactant such that the surfactant isn't able to do its job, and sometimes some alveoli will close or not participate in respiration. The technical term for collapsed alveoli that I've been describing is atelectasis. So from this point, I might use atelectasis a little bit more than collapsed alveoli. And so there are two main branches of atelectasis that could be described, or two causes: obstructive and non-obstructive. Obstructive atelectasis involves a blockage, so think like a physical something in the lung, such as like a mucus plug or a foreign airway obstruction. So thinking about something that is physically causing the atelectasis, not something that is pressure related, but there is physical obstruction, right? And then non-obstructive involves increased pressure on the lung. So where the mechanism of the atelectasis or collapsed alveoli is pressure related rather than physical related. So there can still be something like, think like some fluid with pneumonia or something, but the issue is that the fluid itself is decreasing the surfactant, and therefore the surfactant isn't there to reduce surface tension, and it's easier for the lung to collapse or some of those alveoli not participate in pulmonary respiration. So circling this back to PEEP is what we need to do now. And as we touched on in my little introduction about what this whole focus is going to be, the goal of PEEP is increasing oxygenation for patients. So PEEP increases end-expiratory pressure and therefore combats atelectasis. So what we were talking about earlier, where different parts of the alveoli might not participate in every breath, not every little balloon will expand in every breath, therefore decreases oxygenation, of course, is PEEP increases the end-expiratory pressure for patients who are dealing with non-obstructive atelectasis. In patients with obstructive atelectasis, increasing airway pressure will not have an effect on, like, if there's a foreign body in the lung, if there's something physically in the way, increasing the pressure isn't going to have a positive impact necessarily on the patient's oxygenation. But if the issue with the patient's oxygenation is the alveoli aren't all expanding and participating in pulmonary respirations, inhalation, they aren't expanding and exchanging oxygen for CO2 with the body, then PEEP can be a really, really helpful intervention. Indications for PEEP. When is PEEP used? The main indication for PEEP is failure to appropriately oxygenate a patient. So a patient with low oxygen saturation, even when providing mechanical ventilations via bag valve mask with 100% oxygen. So if a patient has, say, fluid in the lungs, and they're conscious and they're breathing on their own, but they're having some respiratory distress, PEEP isn't our intervention for that patient because they are breathing for themselves. Our intervention, as long as they are able to understand what's going on, as long as they aren't tiring out, as long as they're not altered, our intervention for them would generally be CPAP, which continuous positive airway pressure, right? Where we apply a mask to the patient that applies pressure, but the patient manages their own respiration, their own breathing in and breathing out. For PEEP is a patient that we're moving air so we can see that we've got a good mask seal. It's someone who can't breathe for themselves, so we're using a bag valve mask. We've got a good mask seal. We're using 100% oxygen. We're breathing for the patient. We can see that the lungs are opening. We can feel air go in. Maybe there'll be a little bit of bagging resistance, but we're also using oxygen saturation monitoring, and we're seeing that this patient's oxygen saturation isn't reaching the levels that we would like it to, right? So PEEP is, just as we were watching with the pig lung there, it's used to help increase oxygen saturation. And so here we're going to start talking about different situations where PEEP can help increase patient oxygenation. So we'll start with congestive heart failure, right? So the heart doesn't pump enough blood to the body, and fluid starts to back up in the body in areas such as the feet or the lungs, and the extra fluid in the lungs can cause respiratory distress, respiratory issues, right? If you're trying to breathe, we talked about how the surfactant can be interfered with, and if there's just fluid there hanging out, let's say in the bottom of the lungs, then air can't get there, right? Air can't get to the spots that are full of fluid, and air is not going to be able to exchange oxygen with CO2 and adequately oxygenate the patient. So they might feel short of breath. They might be sitting up trying because it feels like it's harder to breathe. They lay back trying to get air in. Maybe they're breathing really fast, or it sounds, you listen to their lungs, it sounds like there's a bunch of fluid in the bottom, or maybe there's decreased lung sounds in the bottom. It doesn't seem like they're able to get air in very far. PEEP can be an intervention for this patient, right? So you apply the PEEP in this patient. Let's say it came in as respiratory distress, but you get there and they're so altered, they're having tons of trouble breathing, unable to breathe for themselves, don't know what's going on. If you hear just crazy gurgles and tons of extra fluid, the pressure from PEEP can help push fluid out of the lungs from the alveoli to the interstitial space, right? And just as we were looking with the pig lung, as you breathe with the BVM, each breath maintained with PEEP can help push that fluid out, and each breath maybe recruits a few more alveoli, right? Bit by bit, more alveoli that had been full of fluid or had been collapsed and hadn't been exchanging air are recruited, and each little bit helps more oxygen enter the body and more CO2 get out, as we were saying, because that's where the gas exchange occurs. Another example of a patient, PEEP can be used to reduce work of breathing and help ventilate a patient. For COPD is kind of a tricky one, right? Because if you think about it, it kind of seems counterintuitive to use PEEP if you think that a patient's decline is related to COPD, because COPD is mainly an expiratory problem, correct? So chronic obstructive pulmonary disease, the patient is having trouble getting air out of the lungs, and due to that, they can't get more air in, fresh air in, for respiration and for oxygen exchange. So sometimes it can, like I said, reduce work of breathing and help ventilate these patients, but it's important to think about what's going on with the patient. Air stacking could occur, so you're putting basically stale air on top and stale air on top. If you're thinking about the lungs, you're pushing this air in and not all the air is leaving. So let's say the fresh oxygen that you are mechanically ventilating into a patient then doesn't reach the alveoli because the other air hasn't been able to leave yet. So this would be one to know the local protocol on the situation. Another is ARDS, acute respiratory distress syndrome. So this would be fluid buildup in the alveoli. And there are many causes of fluid buildup, but this is a syndrome. It's just a collection of different clinical symptoms, right? So think like ARDS is acute respiratory distress syndrome, but let's say there's like cardiac ischemia, right? Or there's a collection of symptoms that sometimes indicate a clinical cause. And so this would be fluid buildup, and respiratory distress and hypoxia are a result. And PEEP is great to help push fluid out. That is PEEP at its prime. What PEEP is meant to do, why we do the intervention, is because there's fluid, there's some sort of non-obstructive cause that is, as we were talking about atelectasis, we'll keep going back to that. There's a non-obstructive cause that therefore is causing oxygenation to be lower. So these are the type of patients that PEEP will be really beneficial to. Drowning, right? So there's fluid in the lungs due to wet drowning. It's important to note because dry drowning can occur as well, which is just wet drowning. A patient's lungs actually fill with fluid. Dry drowning, sometimes mentally, people are able to shut their airway, basically. They don't open their mouth, but they go hypoxic and unconscious, and it's a similar thing, except their lungs aren't completely full of fluid, right? At least not initially. So suctioning the airway is important, right? If the lungs are full of fluid, you can't push all of that fluid into the interstitial space. But you suction as much fluid out as you can, right? And it's not like your suction device is going to get into the alveoli. It's tiny, right? The suction device might be able to remove the quantity of volume, but the suction itself won't handle any of the fluid in the actual airway exchange, the alveoli. It won't get any of that fluid, and therefore, even if you're pushing air into the lungs, no gas exchange will likely occur. So as we've been going with this consistent theme here, PEEP is used to push water out of the alveoli into interstitial space. And thinking back to the pig lung, as you push that fluid out, though, and you have that end-expiratory pressure, the alveoli will stay recruited, and hopefully you get them back into pulmonary respiration, and in that case, deliver oxygen to tissues that haven't received oxygen recently, right? So chest trauma. Let's move to a little bit of a different idea here. Pneumothorax is a result of chest trauma. So air is a pneumothorax, or blood, hemothorax. Exerts pressure on the lung from the pleural space, and increased pressure causes atelectasis, right? As we've been talking about. If there's too much pressure on the outside, that could collapse the lung, right? Which is, if the lung is collapsed, all those alveoli are smushed closed and aren't participating in pulmonary respiration. So that's pressure that's coming from outside the lung, right? The pleural space. Increased pressure then smushes the alveoli, collapses the lung, and air isn't being moved through. Quick note on pneumothorax, just something that I like to include for chest trauma, but also for not chest trauma. Sometimes spontaneous pneumothorax can occur, and the most likely type of physical profile for someone to have a spontaneous pneumothorax is a tall, skinny, adolescent to younger adult male, right? So that's something that I just like to include because it's interesting. And if you have, let's say, a 6'3", 150-pound, 17-year-old male, suddenly a ton of chest pain on one side and lung sounds, you can't hear anything on one side, just keep a spontaneous pneumothorax in your head as a possibility. And in this case, either way, there's an outside pressure closing the lung. Again, continuing with the theme, PEEP increases that pressure inside the lung and can help either recruit alveoli or open up the lung kind of at the same time and allow that to the lung, or if there's a section of the lung even, it allows more alveoli to open and to continue to participate in pulmonary respiration. Let's think about lung sounds, right? So you're in the field, there's a patient that you are, let's say you're trying to breathe for, you're listening to lung sounds as you ventilate the patient, and there's super wet sounds, crackles, or you can't hear much. You know, you've got a good mask seal, but there's some resistance maybe, and it's extremely diminished in the bottom. You might hear like growls or crackles. Junky lung sounds can be a mixed bag. Why I include this is sometimes using a lot of pressure, if let's say there's just a ton of mucus in the lungs, you can kind of push that mucus even from somewhere where the patient might be able to kind of sit in one of the bigger areas. You might push it down and jam up the alveoli. But if in the case that oxygenation is not occurring, or it's not occurring well enough, even with 100% FiO2 or 80% FiO2, as much, you know, you're in the field, we're in an emergency setting, you need to try things to increase that oxygenation. And if you've got a lot of oxygen, you're ventilating for a patient and it doesn't feel like there's a large, you know, upper airway obstruction. It's not that there's a ton of vomit in the airway. It's not that they had choked on a hot dog and air isn't reaching the lungs at all. This is more someone where air is reaching the lungs, but the lungs are not participating extremely well in pulmonary respiration. So that's kind of why I know to consider other issues if stridor or other upper airway sounds are noted. And the idea with that is that stridor can be more of an upper airway obstruction, or indicative of something more in the upper airway, which isn't what PEEP is meant to fix. As our invention, PEEP is a lower airway obstruction. And if you hear signs that indicate or think that it might be more of an upper airway issue, then consider investigating that before going to PEEP. Let's talk about contraindications of PEEP here for a little bit. So PEEP does not have very many contraindications, and it varies significantly by your protocols. Some places have no contraindications, some have a couple, but they are all centered around the same idea, is that PEEP increases intrathoracic pressure, which can decrease perfusion, right? It can decrease blood flow, right? And so the contraindications of PEEP are a situation where blood flow is of utmost importance, right? So situations of shock, situations of cardiac arrest. The idea for PEEP is that your patient has great blood flow, but you're not exchanging oxygen for CO2 as much as you would like at the alveoli. If your patient doesn't have good blood flow, that's something that has to be fixed before getting lots of oxygen pushed into the alveoli matters, because that blood has to move through, and the CO2 and oxygen exchange, the gas exchange that happens at the alveoli has to occur. If blood's not moving through the alveoli at that area, then whether the alveoli are full of oxygen or not, the body is not going to get oxygenated blood. So with the side effect, basically, of PEEP increasing intrathoracic pressure, which can therefore decrease blood flow, decrease perfusion, if you are concerned about perfusion already, applying PEEP to a patient will likely mildly reduce their perfusion. And if that's the case, and that's already an area of concern, then the PEEP might not help very much, because their blood isn't flowing very well, basically. And so that getting the blood to cycle through is the first step, and is definitely more important than having not much blood flow, but oxygen in the lungs, because that oxygen's not going to get to the body without blood flow anyway. So sometimes some protocols will have contraindication as cardiac arrest, right? The most important thing about cardiac arrest is perfusion. And even if your patient is sitting at 88%, moving, even 85, even lower, moving that blood flow through is more important than not having that blood flow at all, because cardiac arrest, moving that's why we do CPR, right? Because we want that blood flow through. Sometimes there's relative contraindications, such as hypotension or other shock states. So that's what I was talking about. That basically patients have to be hemodynamically stable to tolerate PEEP. And so if they aren't hemodynamically stable, yes, they're working on that hemodynamic stability, working on having good perfusion, adequate blood pressures is going to be your first step, rather than trying to oxygenate the patient, because blood flow is kind of the priority there. The thing is that lots of times protocols will give you freedom to interpret this, and I guess what I would say with that is that if the patient is in a shock state and you are sure that it is due to lack of oxygen, and you're sure, or you have a very strong idea that oxygenation is caused by a condition, let's say ARDS, let's say acute respiratory distress syndrome, let's say that you're sure that that's how the patient got to their condition, lots of times protocols will give you the freedom to say, this is what's going on, this is how the patient got here. PEEP can be applied even in the shock state, because the etiology of how the shock state occurred, or how I believe it occurred, leads me to think that PEEP could help get them out of the shock state. So again, this is one for local protocols, but the idea to remember with PEEP is that the trade-off is sometimes perfusion, intrathoracic pressure increase, right? And so if that is already an area of concern, use a lot of discretion, use a lot of thought before applying PEEP. Even if it's not your protocols, it's good to know that is the main downfall, the main trade-off that we're making. So just kind of talked about intrathoracic pressure. It's the reason for the contraindications that we were just talking about. Sometimes increasing intrathoracic pressures can have positive effects, such as in CHF. In CHF, PEEP can sometimes actually, increasing the intrathoracic pressure can limit the amount of fluid going back in the heart and prevent the backup that fluid backup from getting worse, actually. There's some literature that supports that. Generally, CHF exacerbation, you'll see the fluid in the lungs, maybe they've got a medical history, you get really good lung sounds. It's not one that is really on the fence. PEEP is something that will have a positive impact there, but just a thing to know that intrathoracic pressure can go either way. Sometimes it can even be mildly helpful, but most of the time it's going to cause a decrease in perfusion. One thing to note here is barotrauma, right? So it's been reported that sometimes some injuries caused by EMS is related to providing mechanical ventilation via bag valve mask, right? So hyperinflation of alveoli is a dangerous complication of PEEP on some occasions. Just be careful with conditions already related to air trapping. So we talked about COPD and we talked about asthma a little bit, how those are situations to be really careful with applying PEEP. Let's say that the patient, they might have air trapping. So those alveoli the issue might be that air isn't getting pushed out of the alveoli. Using the balloon analogy I was talking about earlier, the balloons aren't pushing enough air out to be reinflated with fresh oxygenated air. So if those alveoli are already pretty full, and then you've got a bag valve mask and someone's squeezing it really hard and using very large volumes, that can cause injury, right? So, and this goes for patients that PEEP isn't even being applied on, right? A bag valve mask, lots of times when you're doing that, it's a more critical patient. People are stressed out. It's important that, let's say, PEEP has been delegated, that bag valve mask has been delegated, for everyone on scene to just, be aware to not squeeze the bag completely full, grab it with both hands and mash it down. Lots of times using a one-hand technique. Just be careful with bag volumes and forcefulness as well. So if you're dealing with a pediatric patient, make sure you've got the pediatric bag. PEEP just increases the pressure on the lungs, right, as we apply mechanical ventilation. And so as that pressure is increased, our chances of causing an injury can also be increased just by the fact that we have additional pressure on top of this already somewhat dangerous intervention, or intervention that can be dangerous when done incorrectly. So talking about the physical application of PEEP, we've talked about this, or we watched it a little bit with the video, is PEEP, positive end-expiratory pressure, is applied through a valve that's attached to a bag valve mask. So I talked about it a bit at the beginning. It's essentially a spring that the patient breathes against. So the exhalation force, I guess, is against, right? Because we're providing mechanical ventilation. And many newer bag valve masks have the PEEP valve attached and ready to go from the beginning, but it's just set at 0 for PEEP, 0 centimeters water, H2O, which is the pressure reading, what we'll get into. So the PEEP valve is there, but it's not applying any extra pressure. If let's say you work for an agency that might not have updated the bags, or has a special brand, or buys the cheapest brand. I know that sometimes there's not that much money out there. Just be aware and know in your equipment, do you have to apply PEEP via a special valve, or is it already a part of your bag that you just have to modify on the bag on the go, right? For me, I apply a valve. It's a separate attachment. It's just a little valve, attaches to the BVM. You can twist it, it's a spring, and PEEP is applied. Just like in the video, know how you're at your agency, how the equipment works. And choosing a pressure. Most PEEP valves go from 0 to 20, as again we were talking about in that little video that we watched. We talked about the PEEP integration. And so on the newer models, like we were saying, all that's required is twisting the end of the BVM. Sometimes you need to put the valve on and then twist it. But either way, physically, it's quite a simple application. It's quite a simple intervention to do. And then you start with usually 5 centimeters of water, which is, again, the measurement, which is just the pressure measurement. And PEEP can go up to 15 or 20 generally. So this is another protocol. The protocols used to be a little bit more conservative and not allow for quite as much PEEP, but some of the newer literature is indicating that the gains from having higher pressure outweigh the risks of having higher pressure. So You can get up to 15 or frequently 20. I believe currently in the area that I'm at, it is 20. But you have to go there incrementally, right? So you start at 5 and you work your way up, especially, let's say, you hear a little bit more lung sounds, right? With the PEEP, you hear more air moving in and out, or you were bag valve masking a patient, you were mechanically ventilating for them. And when you started, even with 100% oxygen, they were only getting up to 81%. But then you started applying PEEP, and suddenly they're at 85, 86%. Maybe bump it up from 5 to 10. Maybe that helps them climb a little bit if you plateau in a certain area, or you're still hearing, this is again a lung sounds thing, you're still hearing very diminished lung sounds. That would be if maybe you had an improvement with a little bit of PEEP, you continue bumping that PEEP up a little bit by bit, and seeing increases in the patient's oxygenation, which is, as we talked about right at the beginning, our primary goal of the intervention itself. So we'll go through a little scenario here. We got a 55-year-old male, presents at home with extreme shortness of breath. Skin signs are pale, cold, and moist. Patient is breathing 48 times a minute with heavy accessory muscle use. Bilateral crackles, and history taken from son who lives with him says he has heart failure, right? And so just thinking about this patient in general, is this patient stable? Are they able to provide adequate ventilation for them? With pale, cold, and moist, the skin signs aren't good. 48 times a minute, is that a healthy respiratory rate? I would argue that it is not. Almost any textbook, anything you see, and field experience would argue that 48 times a minute is not a super sustainable respiratory rate for adequate ventilation. And the crackles tell you there could be fluid in the lungs, and heart failure, to me, when I hear someone's son say heart failure, I think a lot of CHF, congestive heart failure, right? So, impression of the patient. Initial vital signs are SpO2 of 73%, blood pressure of 155/75, CBG of 145, respiratory rate now it's down to 40, and sinus tachycardia on the 12 lead. The impression is a patient male in serious respiratory distress due to fluid overload in the lungs. Patient now appears conscious. Let's see. Yep, he's still conscious, alert, and oriented. The patient is in acute respiratory distress and is hypoxic due to pulmonary edema. We're saying that there's fluid in the lungs from congestive heart failure. That's what we're going off as our impression of what could be going on. Does this patient meet the criteria for PEEP? Think about it here. We'll give it just a second. Just thoughts on whether PEEP should be immediately applied to this patient? No, not necessarily right at the beginning. Again, the patient's respirations are not sufficient at this point. But the respiratory rate's going down. They're alert and oriented. In this scenario, we'll say the paramedics start getting a CPAP mask on the patient, and as they're applying it to the patient becomes more and more sleepy and starts losing consciousness. So I think the idea in this scenario is paramedics are thinking oxygen and will apply some pressure. The patient understands CPAP. They can be coached through it. They're alert and oriented. Even though their respiratory rate is fast, we could push some of the fluid out and it would help this patient. But suddenly, patient's more and more sleepy and starts losing consciousness. So the patient now requires immediate respiratory intervention and mechanical ventilation by BVM. Does the patient meet criteria for PEEP now? Yes, 100%. So the patient has fluid in their lungs, causing atelectasis and lack of oxygenation. So with a bag valve mask and 100% FiO2, the patient only rises to 78%. This is prior to PEEP being applied. So the application of PEEP could, in this case, open up the alveoli and allow more pulmonary respiration to occur. Think back to the pig lung video, how the lungs start closed and then adding PEEP as an intervention can increase oxygenation because there is more surface area for oxygenation to occur, right? So as the blood flow, as the gas exchange occurs in the surface of the alveoli, the more alveoli there are, the more oxygen can therefore go into the body and oxygenate the patient's tissue. In this case, remember to start at 5 centimeters water pressure and work up as protocols allow. And as you'll see on a PEEP valve, if you're familiar with it, it's a twist where you twist the spring more generally to apply pressure. One full turn usually goes up 5 centimeters water pressure at a time, and it's clearly marked on how to increase that pressure. One more thing to note for PEEP is that generally it goes up by 5 when we're using a bag valve mask, but if you're dealing with a patient who is mechanically vented and intubated, PEEP settings usually go anything by increments of 1. So if you transport patients who are on vents, their vent setting could be a respiratory rate of 18 and a PEEP of 8, for instance. And why these patients on vents have PEEP is so that when the patients aren't providing their own oxygenation, those patients are not losing alveoli, no collapse, no atelectasis. They're still recruiting all their alveoli, and it's possible to oxygenate that patient even when they're vented and not breathing for themselves for long periods. So we talked a little bit about contraindications. Even with the PEEP application, the patient could hypothetically have been hypoxic for a long time or have a medical issue and crash to shock or cardiac arrest. So even if you're actively providing PEEP to this patient, if the condition changes, PEEP could be contraindicated and need to be removed from the patient as perfusion becomes the chief concern of patient care over oxygenation, right? So if a patient's heart isn't beating, giving them oxygen isn't going to be as important as moving blood through their body with the oxygen that you can get in, right? That oxygen isn't going to bring them back to life again. Talking about cardiac arrest, the big things that you want are high quality CPR, and early defibrillation. So CPR is talking about that perfusion again. So if perfusion is adequate, then oxygenation is the next step. If perfusion is not adequate, oxygenation won't matter because blood's not getting where it needs to go. So just remember that even if PEEP is indicated for a patient at some point, if you are mechanically ventilating for a patient, the patient goes to a condition of cardiac arrest, let's say, and your local protocols say no PEEP during cardiac arrest, remember that you might need to take the valve off, you might need to unscrew it so the PEEP application does not occur, that PEEP can be indicated, and as the call progresses, it might not be indicated anymore. So kind of in conclusion, everything that we talked about today, PEEP can be a really positive intervention to increase oxygenation in patients. It has a range of applications due to the variety of different causes of atelectasis, which, as we've talked about, is the collapse of alveoli, which then reduces surface area for gas exchange, oxygen, CO2 exchange to occur. PEEP fits a role for hemodynamically stable patients who are not able to provide adequate ventilation and oxygenation for themselves. Once a patient becomes hemodynamically unstable, make sure to know your local protocols, because some medical directors, depending on who creates your protocol, some are okay with PEEP in all situations. Some, there are contraindications that we've talked about. So that's a situation where it varies a little bit. And even if everything is allowed, understanding some of the drawbacks of PEEP can be valuable for how you treat a patient, because there's always flexibility for providers within protocols, and knowing all the positives and all the negatives of an intervention such as PEEP can help you provide the best patient care possible.
Now let's transition into some multiple choice questions.
First question. Select all airway interventions that provide positive pressure to the lungs. Select the 2 answer options that are correct. Options include CPAP, nebulizer, non-rebreather, or PEEP. The 2 correct answers are CPAP and PEEP. While a nebulizer and non-rebreather flow pressurized oxygen, they do not provide a direct positive pressure to the lungs like CPAP and PEEP do. Next question. Which of the following is a goal of PEEP? Options include increasing blood pressure, increasing oxygenation, medication delivery, or improving blood flow. The correct answer is increasing oxygenation. PEEP works to stent open the alveoli, with the major goal of improving oxygenation by improving gas exchange. Next question. Pursed or puckered lip breathing is a sign of respiratory distress that patients will exhibit in an attempt to do which of the following? Options include increase PEEP to prevent small airway collapse, decrease PEEP to prevent small airway collapse, increase PEEP to ensure adequate oxygen intake, or decrease PEEP to ensure adequate oxygen intake. The correct answer is increase PEEP to prevent small airway collapse. Pursed lip breathing is a true sign of respiratory distress. It should be noted while you are placing oxygen on the patient. Next question. For which patients would high PEEP be contraindicated? Options include untreated pneumothorax or bronchopleural fistula, pulmonary edema or CHF, untreated coup-counter-coup or ICP, or subdural bleed or epidural hematoma. The correct answer is untreated pneumothorax or bronchopleural fistula. High levels of PEEP will place additional pressure, potentially leading to collapse in patients with conditions like pneumothorax or bronchopleural fistula. Next question. Why should PEEP be used judiciously in patients with poor cardiac output? Options include increased pressures can result in diminished preload to the right atrium. Increased pressures can result in diminished preload to the left atrium. Increased pressures can result in diminished preload to the right ventricle. Or increased pressures can result in diminished preload to the left ventricle. The correct answer is increased pressures can result in diminished preload to the right atrium. Increased PEEP can increase pressure within the thorax, further decreasing venous return and ultimately cardiac output. Next question. Positive End-Expiratory Pressure, or PEEP, is often used as a lung protective ventilation strategy. The main reason for this is to options include decrease significant tidal volume, improve oxygenation while preventing alveolar collapse, increase gas exchange with an increased FiO2, or increases respiratory rate to optimize the patient's ventilation. The correct answer is improve oxygenation while preventing alveolar collapse. PEEP aims to help maintain pressure within the lungs at the end of expiration. Our body naturally does this when we can breathe on our own. However, when mechanical ventilation is provided via a ventilator, PEEP can be used to maintain this pressure at the end of exhalation, which helps keep alveoli open and improves alveolar recruitment, ultimately improving oxygenation. The correct usage of PEEP is a critical piece when providing mechanical ventilation. PEEP does not increase respiratory rate or FiO2, nor does it decrease tidal volume with ventilations. Next question. You deliver a premature baby en route to the hospital who is presenting with difficulty breathing. He has insufficient surfactant to keep the alveoli inflated. Which ventilator option is best? Options include PEEP, negative pressure ventilators, BiPAP, or CPAP. The correct answer is PEEP. PEEP, or positive end-expiratory pressure, can be used for premature newborns who have insufficient surfactant. Positive pressure ventilators are preferred over negative pressure ventilators. CPAP is used to keep pharyngeal structures from collapsing at the end of a breath, and BiPAP is used for patients who require more pressure than CPAP. Next question. What two settings on BiPAP do we use to control the pressure the patient inhales and exhales? Options include IPAP and PEEP, EPAP and PEEP, IPAP and EPAP, or PEEP and CPAP. The correct answer is IPAP and EPAP. IPAP is always set higher than the EPAP. Most textbooks and web sources suggest an initial IPAP setting of 8 to 10 and an EPAP setting of 3 to 5. Next question. Select all conditions that can be caused by PEEP. Select the two answer options that are correct. Options include increased intrathoracic pressure, decreased intrathoracic pressure, expansion of the alveoli, or constriction of the alveoli. The two correct answers are increased intrathoracic pressure and expansion of the alveoli. Utilizing PEEP will maintain a constant pressure within the lungs, which will maintain alveolar expansion, recruit collapsed alveoli to open up and expand, as well as cause an increase to intrathoracic pressure. Last question. You are transporting an intubated patient who is currently being ventilated through a ventilator. What should the initial PEEP setting be? Options include 0 centimeters H2O, 10 centimeters H2O, 20 centimeters H2O, or 5 centimeters H2O. The correct answer is 5 centimeters of H2O. PEEP should initially be set to 5 centimeters of water. This maintains PEEP at levels found in a normal, healthy person.
Thanks for tuning in to EMTprep Pulse Check. If you found today's episode helpful, be sure to subscribe, leave a review, and share it with your classmates and crew. For more test prep tools, study guides, and practice exams, head over to EMTprep.com. Until next time, stay sharp, stay safe, and stay on pulse.